Good afternoon, everyone. I'll be talking about various presentations of orbital lymphoma. Lymphoma, as we all understand, lymphoid tumors are the most common primary orbital malignancies and constitute approximately 10% of all orbital tumors, have a propensity for the disease in orbit. Majority that are present are presenting in the adult age group, and the non-Hodgkin's type is seen primarily. They are usually unilateral, but they may be involving both the orbits, may be asymmetrical, and have a predilection for the lacrimal gland region. Uh, uh, the classification is based upon their clinical severity, and they are classified into indolent, aggressive, and highly aggressive type. The most common ones to present in the orbit are the small cell B cell type of lymphomas, which are indolent type, and they are slow to progress and gradual, usually gradual in onset. Ann Arbor staging, which was initially given for Hodgkin's lymphomas, is applicable to non-Hodgkin's lymphomas as well. And orbit, we understand, is an extranodal site. And patients with orbital lymphoma usually present with a gradually progressive painless proptosis of insidious onset, and the features will depend upon the location of the tumor. And it usually presents as a mass which molds around different orbital structures around the eyeball, around the muscles, or involve the lacrimal gland fossa. There's no globe indentation seen, and there can be a gradual bony remodeling that might be seen in a long-standing case. Approximately 85 to 90% are low-grade diffuse proliferation of monoclonal B cells, and the remaining are higher grade follicular or nodular lymphomas. And immunocytochemistry or immunohistochemistry plays a major role in identifying and typifying these lymphomas. And CD20 is for mature B cells, CD10 for precursor B cells, CD3 for T cells, and PCR for monoclonality plays a big role when the diagnosis is really in doubt. Uh, a combination of chemotherapy and a radiotherapy is the appropriate and most commonly followed regime. Chemotherapy, this is a commonly followed regime, the CHOP cycle, which is given in form of cyclophosphamide, doxorubicin, vincristine, and prednisolone. And but nowadays the first line treatment that has come up is rituximab, which is given along with the CHOP regime. And in fact, our medical oncologist at our institute, he for very localized tumors, he only gives rituximab, doesn't give CHOP. But rituximab in combination with CHOP is the commonly followed regime nowadays. Rituximab has high affinity to cells expressing CD20 antigen, and it is administered as a infusion. And outpatient therapy is feasible on a daycare basis, and it has a good response rate. This is a patient who presented to us with a right-sided gradual onset proptosis. The patient had a Salmon patch. This is the presentation of the tumor cells in the subconjunctival space. This is very classical and identifies a lymphoproliferative disease. CT orbits showed cells molding around the eyeball, and had the patient underwent a FNAC which showed presence of B cell lymphoma. Uh, uh, Now, two, three unusual cases I'll show. This patient presented to us with a left lower eyelid region mass, which was well localized. On radiology, we did a mass excision for him, but the final diagnosis was a B cell low grade lymphoma. This patient presented with a progressive blepharotosis of upper eyelid. There was a mass in the supratemporal region, which presented like this. There was globe indentation. There was bony expansion. We thought of a benign pleomorphic adenoma. Went ahead with mass excision. The final diagnosis, however, was a B cell type of non-Hodgkin's lymphoma. This patient presented with a bilateral presentation, had a subconjunctival presentation as well. The CT showed a diffuse mass involving the ethmoid sinuses, frontal and the orbits. The patient underwent an FNAC, which showed reactive lymphoid hyperplasia. We were not very convinced. We went ahead with a incisional biopsy, and the final biopsy result was a B cell type of non-Hodgkin's lymphoma. Reactive lymphoid hyperplasia is a benign proliferation of lymphoid follicles, and this is in fact a more common presentation of a lymphoproliferative disease in the orbit. But these patients, when followed up, have a 1 in 4 risk of developing a systemic lymphoma. So these patients, if they have been diagnosed as reactive lymphoid hyperplasia, have to be kept on a close follow-up. In benefit of time, I'll skip the last one. That's all that I had to say. Thank you.
Thank you very much.
Any questions from the audience? I think he covered everything almost except low dose radiation perhaps and
Yeah.
intraorbital rituximab.
Intraorbital radiotherapy is the low dose radiotherapy, not the brachytherapy part. The external radiotherapy has now really come up, and with that, some of the radiation induced retinopathy and cataract, they are really avoided, and the dose delivered is lesser but is at a precise location, and that is what is coming up really in orbital radiotherapy.
Yeah, we call it the ultra low dose radiotherapy.
Yeah.
So the conventional is 2400 to 2500. Now we have come down to 200 by 200 because we all know that low grade extramarginal zone lymphoma melts with radiation, and believe that that's good enough for it.
And some people also now have started giving subconjunctival rituximab, which also is now coming up. Though we haven't started it yet. I mean, we are with Dr. Feroz. You have presented that some time back, I remember. Can you elaborate on your experience with that?
Yeah, basically rituximab is actually something which is anti-CD20. So when we do the IHC, extramarginal zone lymphoma, which is usually CD20 positive, rituximab really acts locally. So injection rituximab is given either into the orbit or into the conjunctiva for the tumor for treatment. So that is one of the things that is new in orbital lymphoma. Yes.
Way to avoid radiation. If you cannot remove, suppose the tumor is going around the eyeball and going posterior to the equator, by meddling with it, you are interfering with the function of the eye. So, and also you want to avoid complications of even low dose radiation, then you can use perilesional or intralesional rituximab. 5 milligrams is 5 to 10 is what we use every 3 weekly for 6 injections.
Thank you, Dr. Pankaj.